thank you once again, and then we're going to move on, if that's okay, to our first transfusion bite, and this is given by Sam Carrington. Sam is a registered biomedical scientist with 10 years laboratory experience, and for the past 3 of those, she's been a transfusion practitioner at Southampton University Hospitals. And her presentation is entitled Reducing Platelet Wastage by Increasing Stock Levels. That's interesting, isn't it? Because we normally try and reduce stock levels. So Sam, over to you, please.
Okay, so I'm just going to talk today. I'm just going to give a brief overview about a pilot project that I ran to do with reducing platelet wastage by actually increasing our stock levels. Just want to caveat this by saying we found that this is what works for us because we're a very large site that use a lot of components. It's not going to work for everyone. So as we all know, donations are altruistic gifts. It's our responsibility to ensure that they are used appropriately. And as we're also aware, our supply chain is becoming stressed. We've had amber alerts and pre-amber alerts issued for red cells and platelets. And there are actually NHSBT forecasts that predict that we're going to need 1,800 new platelet donors to meet a 6% annual demand increase. And as well as just the national pressures, we're also having some local pressures in this post-COVID era. So at UHS, all our budget holders have been asked to reduce spending wherever possible. So we thought that we could look at what we could target, and wastage it just sprung to mind as something we could target quite easily. So for those of you that don't know, UHS, we're a large acute teaching hospital. We have multiple specialities, the trauma centre, specialist cardiac surgery, neuro, fetal medicine. We're categorised as a very high user of components by BSMS. Last year, we received over 8,000 units of platelet. But our platelet WAPI is currently sat at 10.1%, when ideally it should be less than 4%. And that equates to between 60 and 90 units of platelets being wasted per month. And it cost UHS just over £250,000 last year. So we thought that, like I said, we would target this. So we thought we'd start off targeting this by auditing. You could move me on, please, Francis. So we looked at 6 months of platelet usage. And usage by department. We looked at how many we issued to them, how many they transfused, and then how many they wasted. And it's no surprise that hem-onc followed by cardio are our biggest users and therefore biggest wasters. So then we thought we'd break it down a bit more and look at why they're actually wasting so much. And the way things work at UHS is we have a very small stock platelet, basically for trauma use, and everything else is ordered on a named patient basis. So it takes a couple of hours to get platelets. So there's a long time between clinicians ordering the platelets and them actually being available for use. So that led to a lot of just in case ordering. So I thought that, we thought that if we can reduce the turnaround time from ordering to issuing, it should then reduce the just in case requests, and then we get more appropriate requests. Also, sorry, all the questions are popping up. Also, because of the long turnaround time and the clinical pressures on the wards, the nurses don't always get the time to come back around and transfuse their platelets within the dereservation time that we put on our platelet. So can you move me on, please, Francis? Thank you. So from that audit, we broke down further to look at how many platelets we use per day by blood group and if they have special requirements or not. And we use this to guide our new stock levels. So the majority of our patients actually receive group O or group A, and they have more with special requirements. Well, there's a high proportion with special requirements, and as always, Monday to Friday are busier than the weekend. Can you move me on, please, Francis? Thank you. So these are to reduce the time taken. We said we'd increase the stock levels. We did have to put forward some proposed stock levels. We had to consult with NHSBT to check that these were feasible, and it wasn't going to stress the supply chain even more or increase the workload at our local stock holding unit, which is actually on site, because we don't want any changes we make to be detrimental to them. They actually suggested, they agreed with our levels, but they suggested that all our stocks actually have special requirements. We have an ongoing battle with our heme consultants here, and all our transplant patients, heme transplant patients, must still receive CMV negative requirement. We can't do anything to change that at the moment. So therefore that increases the kind of special requirements that we need locally. You can see that our proposed stocks went from having 2 standard Group A and 2 Group A with special requirements to 8 APOS and 2 ANEG. We increased the O's from 4 to 8, and then we also had ONEG and BPOS because that's what we needed. And our stocks are like done by VMI, so we have to set trigger levels of VMI. VMI will look at our stocks prior to a routine delivery. It will generate an order to our stock holding unit. They will do the top us up to our proposed levels. And then in between deliveries, we haven't set a trigger value. We've set our trigger value as 0 because we don't want VMI to be generating an order each time a platelet is used. It will just make it unmanageable for the stock holding unit. Okay, so we did that, and these were the immediate results. You can see June 2023, we've dropped right down in the number of units, and that's through increasing stock levels alone with no other changes. So we thought, great, it is kind of working, but it's not going to be enough to show a sustained wastage reduction. Can you move me on, please, Frances? Thank you. So we did realise that we were going to need to make further changes. With any change, communication is key. We would love to tell our clinical areas, hey, we've increased our stock levels in the lab, so we can reduce your turnaround time. So now you don't need to pre-order your platelets. You just need to phone up when you need them, and we can issue them straight away. But because we no longer have an NHSBT on site at the moment, if we don't have that platelet in stock, we cannot get that platelet anytime soon. The turnaround time has actually increased. So we have to do all this behind the scenes without telling any users that this has actually changed. So that put a lot of pressure on the blood transfusion lab, and they have had to basically carry out the brunt of the work here. So before we actually made this change live, we did do a lot of background work. So we sat down with the haematology. We've kind of integrated ourselves into the heme-reg training. That's become a lot more structured, the training and education surrounding transfusion. And we now ask anyone ordering multiple units of platelets to seek haematology authorization before we will let them have it, unless the patient's actively bleeding or is in surgery. And we also saw authorization at the HTC from cardiac surgery to see if they would accept out-of-group transfusions for platelets, and they said they were happy to do that as long as it was suitable. And then we also reviewed our transplant schedules. We get the consultants now to put on the schedules second choice platelets and third choice platelets so that we don't have to seek authorization if we don't have the first choice in stock, although we always aim to give first choice and ABO RHD matched as much as possible. We also now, because of VMI, we can look at the groups required on the transplant schedule. So if we have a patient that requires AB neg only, we will add that to our stocks for 6 weeks if they're having a transplant, because they're likely to need the transfusion support. So we'll add it to our stock levels. So we'll just ask for like 1 a day for a 6-week period. And then at the end of that 6 weeks, when they're no longer as transfusion dependent, we'll ask VMI to remove that requirement. The lab have had to take over management of the haematology day ward. It's a very busy day ward. They have limited chairs, limited appointment time, and they will not accept any messes them up for the day. So we get their clinic list the night before. We will go through and see who's coming in for platelets. We'll make sure that they are available on the day, and then we'll follow up 2 hours after the appointment if the platelets haven't been used to see if the patient is running late or if they can just be returned to stock because the patient's not coming in that day. Previously, this was managed by the heme-reg in charge of the ward, so they would just have everyone kind of the platelets would all be on pre-order, so they'd all be coming in the day before and issued to the patients. We've stopped all that now, unless the patient requires HLA matched, HPA matched, or wash platelets. And then in the lab, we've had to train all our staff to do a kind of more active stock management, because that's just a skill that we don't really think anyone has anymore. They're so busy just doing general kind of issuing, just trying to keep up with the day-to-day workload, that they don't have time to go back and look at what they've issued, how long it's been sat there for, whether it's actually being used. So to help with that, Francis, can you move me on, please? And this, you can't really read these very well, but we kind of, instead of putting the responsibility on one person, we broke it down into various lab departments. So the MLAs are our blood runners. They will just before the delivery, look at what they're taking out, see if the platelets have a long date on that can be swapped for a short dated unit. The people on phones will offer to get the platelets delivered on the next hourly run that we do, to try and increase the kind of, just actually make sure they get out there and get used. And the BMSs that actually issue it will be looking to see, are there short dated platelets that are more appropriate for this patient that we can issue to get rid of. Can you move on, please, Francis? Oh, okay. But that is not ideal. It's not really addressing the underlying problem, which is, are these actually appropriate requests? But I think communication might help with that. So this is the results of a 12-week study. So this is the same time period in 2022 compared to 2023. Okay, so the blue bars are the cost to UHS in 2022, broken down by week. But overall, the wastage costs for the 12-week period last year was just over £40,000. And this year, our wastage costs have been reduced to £22,500 for the same 12-week period. And last year, the lines are kind of the number of units. So for 2022, we wasted 165 units in that period, and we dropped that down to 85 units this time. And as you can see, as we get further in, like towards the end of the pilot, we actually got a week of zero wastage. So the first kind of 3 to 4 weeks are just reducing the stock levels. The next kind of 5 to 8 weeks, 5 to 7 weeks are where we started taking over the management of the haematology ward and things like that, actively looking at transplant schedules. And then the last thing we brought in was the active stock management by the lab. We had to bring in one change at a time, so not to kind of overwhelm the lab. And it was working really well. But then the pilot stopped, I went on holiday, and we have reverted back to normal. But what we have got from this pilot study is we've managed to now get RBPs approved for 2 jobs for people to actually manage the wastage on a daily basis, so that hopefully we can actually show a sustained reduction. Can you move me on, please, Francis? Oh, I just want to talk about a few limitations. So obviously the closure of the Southampton stock holding unit was a bit of a blow to kind of everyone that is supplied by them. I think we had to be re-provisioned by another site that was not, they didn't use VMI, so it's a big change for them. And then we had to be re-provisioned by a further site after that. Southampton then kind of reopened in an emergency capacity, but we had agreed to take all their short-dated platelets. So there were some days we were getting 8 units of platelets sent over from Southampton that's completely outside our normal stock levels. So it put us in an overstock position, kind of made the lab have to work a bit harder. To say, lack of communication with the clinical teams makes life really hard. And like I say, our BT lab is very busy. Lack of trained staff, we constantly have people training, we're just fighting to get through the workload. So it's a bit of a struggle on a daily basis. I'm sure we're not the only site that sees that. And it's actually, is there appropriate ordering and usage of platelets going on? Is this a kind of a sign of a bigger issue? And I'm not, this, like I say, this is my master's project, so I'm just trying to give you a very brief overview. But part of that was to compare UHS with other sites like us to see if we could then share practice with them and learn from their practice. And what happened was BMS came back to me and basically said, we're struggling to find comparable sites to you, because the larger sites that use the same volume, you cannot rely on the wastage data that's being reported because there are just too few entries to show that this is reliable data. So it sounds like the true extent of wastage is actually unknown because reporting is voluntary. So, I mean, this could be rectified with the development of a full electronic vein-to-vein system where information flows both ways up the chain. But if I can just get a key take-home message to any of you, it's please accurately report your wastage to BSMS, whether you're brilliant, whether you're rubbish like us, at least then we have a true picture of what the wastage situation is like. Can you move me, please? Thank you. And if you have any questions, put them in the chat or feel free to email me if you want to, because I love talking about platelet wastage and could go on like this for hours. Thank you.
Thank you very much, Sam. Thank you very much. That was fantastic.